Hi, I'm Dr. Amol Gupta, and I'd like to welcome you to our podcast, COVID Experts, interviews with top physicians and scientists. Through this podcast, we will share the latest clinical and research advancements across the globe to help you better understand the situation with coronavirus and what our future holds. If you have any questions or concerns, please do not hesitate to email us at info@covidexperts.org. Today, host Dr. Ashish Gupta talks with Dr. Annelies Wilder-Smith, a professor of infectious diseases research at the Lee Kong Chian School of Medicine in Singapore. She is a renowned expert on public health and emerging infectious diseases and has published over 300 scientific papers with more than 10 manuscripts on COVID-19 itself. Today, they discuss a paper that she published in the Lancet comparing the SARS outbreak to COVID-19 and the new challenges and opportunities that the coronavirus presents. Let's listen. Professor, can you share with us your background in dealing with infectious diseases in previous pandemics?
Well, thank you. First of all, let me share a little bit about our experiences during SARS in 2003 in Singapore. We managed to not only contain SARS, but also eradicate SARS. And it was through extreme measures. And at the time, when I lived in Singapore, and when we finally basically eradicated SARS, we all said to each other, the West would never have been able to do so. And so just to remind you what we did, immediate case isolation with a very liberal case definition. Initially, we even did not have a diagnostic test. So we isolated all suspect cases. Later, we had a diagnostic test, and it was then easier to not over-isolate everyone. So we isolated every single case in the hospital. We did extensive contact tracing, and to do so rapidly, we even employed the military. We enforced quarantine of all contacts. And basically, it was still very much a nosocomial infection within hospital transmission. And so using very stringent PPE, despite some initial mistakes, we then had no further nosocomial transmission or transmission to healthcare workers. So it was very synchronous between Hong Kong, Taiwan, us in Singapore, and in Toronto. Almost synchronous time. We managed to, we now call flatten the curve, but also curb the epidemic. As we were doing so and starting to celebrate our success, China opened up with thousands of cases. And I remember being so depressed. Remember that SARS had a case fatality rate, confirmed case fatality rate of around 10%. After an initial denial and some problems, China really reenacted what they did during SARS in 2003, and they were successful. And it did give me hope when we saw that with the lockdown, with all the measures that they took, and they pulled out every weapon that you can do for non-pharmaceutical interventions, then China was again successful in containing this. But unfortunately, because of some of the virus characteristics that are different to our SARS, coronavirus 1, this novel virus is more stealthy and much more difficult. Despite a lot of virus characteristics that are totally similar between SARS coronavirus 2 and 1, the problem is that obviously we now also have pre-symptomatic transmission. And so you have hidden community transmission, which is much harder to get. We did not really take the case fatality rates at face value. And now we know they are. In Italy it's 10%, and in Spain it's 8%. I'll tell you in New York it will not look much better either. So I think we missed the time from January to February to put our minds into a SARS mindset, which means you need to use the weapons that we use to contain SARS. So is it too late? I still believe it is not too late, but we have to enact what China did and do it well and quickly. And to do so, I think, the lockdown now is our opportunity to build up what we did not do in January, February, and that is building up the testing capabilities, but also isolation capabilities, and then the contact tracing. The public health response in Europe and the US has been very poor in terms of contact tracing.
In your professional opinion, what factor is most responsible for this astronomical difference between the Asian and Western countries?
We wasted so much time in Europe discussing whether this is flu-like and whether the fatality rate was 0.1 or 1%. And we did not really prepare what we needed to prepare as testing. Because South Korea also had experience with MERS. No, they had a major MERS outbreak. They had the preparedness plans, so they could just pull it. Whereas the West still had an influenza mindset. And what do you do in comparing it to the H1N1 outbreak? Much more preparedness in terms of availability of face masks. 96% or now 98% of all Hong Kong people voluntarily wear face masks all the time. In Japan, it became, I think, now mandatory. In Singapore, it's voluntary. It's now increasing the uptake. But there's availability. Even if I wanted, I cannot buy a single face mask in Switzerland. I just cannot buy. So if you see the amount of testing done in Asia, it is incomparable to what we do in Europe. And how do you measure it? It's by the test positivity rate. So in Singapore, just to show you how much they test and only 1% is test positive. In the US, the latest data that I saw about 2 days ago was they had tested 1.2 million. It sounds like a lot, but they had 350,000 cases.
I was also interested in another paper you wrote in the Lancet, New Challenges and Opportunities in Epidemic Preparedness. What was your main focus in the paper?
So our pandemic preparedness needs to be much more better tailored towards the megacity response. And a megacity response with a population density that is very high is very conducive to respiratory pathogens. And a response in terms of physical distancing, contact tracing is different now in a megacity setting compared to what we had during SARS or even during the 2009 H1N1 pandemic. I think the Wuhan experience really taught us, what is a megacity response, and China pulled out all the right weapons. So not everything that happened in Wuhan would have applied to the smaller towns in northern Italy, the Lombardy, Veneto. In fact, I looked up the numbers and the village sizes were about 1,000 to 15,000 people. So I think in pandemic preparedness, definitely COVID will teach us a lot. Unfortunately, COVID itself is such a crisis already, and it will change power structures.
You mentioned the importance of testing, contact tracing, and rigorous isolation. As a public health official, what is your perspective on the stricter lockdowns compared to the soft measures?
What you do in a lockdown area can differ. So in Wuhan, it literally meant stay at home. I mean, absolutely legally enforced stay at home. You were not allowed to go out, I think, every second day for a short time to go to grocery, and that was supervised. So the extent of what I call community quarantine within a lockdown area can be totally different. Lockdown is now inward, but lockdown is not the answer. It is the extent of physical distancing between people. That is the answer. And how you play that out needs imagination and needs to be adapted to local situations. The main message of our modeling is the less strict you are or rigorous with your community-based quarantine, the longer your lockdown needs to be, because you will not curb the epidemic if you don't do it very strictly. So that is the message. The message is, if you really want to have success, you better do it right, and you do it 100%. I also want to add, though, you said Singapore. Singapore never had a lockdown. Singapore managed it because they focused so much on going after every single case. And in fact, I was in Singapore just 4 weeks ago, and life was almost normal. I would rather, I call it precision quarantine. Precision quarantine is you identify the true contacts, and they must be quarantined, really quarantined, and the government must help them, to be fed, etc., so that the vast majority of the population does not need to be quarantined. Why should 100% of the population suffer because the government or the system or the public health system was not able to do contact tracing? And I do agree, in this current moment in New York, in Europe, we cannot do individual contact tracing anymore. There's too much community-wide spread. But when we bring it down, then we build that up. That's my message to you and your audience.
Professor, this was truly wonderful. Thank you so much for being with us today.
All the best to you.
Thank you for listening to COVID Experts. Tune in for more conversations with some great minds on the subject. I'm Dr. Amol Gupta. See you next time.